Hello everyone. Today case history includes Mr. Rahim Dad, son of Huda Baksh, 54-year-old Muslim married resident of Gulshan, is admitted in ER with chief complaint of vomiting for 6 days. My patient is a known case of diabetes mellitus since 15 years, hypertension since 4 years, and chronic kidney disease 8 months. He is a non-smoker and there is history of renal stones for which he was operated, and he has history of a key medication and now prescribed with vomiting since 6 days. The vomiting is a sudden in onset, 5 to 6 episodes per day, occurred after food intake, after solid and liquid. Each episode contains 100 ml non-projectile, yellow in color, containing food particles with no blood in consistency, gradually increasing in frequency from 2 to 5 episodes per day. There is no aggravating or relieving factors, and the vomiting is not relieved by any medication. Vomiting is associated with shortness of breath, gradual, progressive. Initially it occurs on walking but now become dyspneic on lying flat and awake in night due to shortness of breath. It is not associated with cough, sputum, fever, and there is no history of inhalers use. Patient used 2 to 3 pillows for sleep. And sometimes gets activity in night by walking around. There is associated burning, urination, but burning does not contain blood or frothy urine. Patient has decreased urinary output and patient does not quantify the amount of urine, but he confirms that there is associated frequency and micturition associated with itching. Patient complains of itching all over the body. Patient denies any history of constipation, abdominal pain, abdominal trauma, high-grade fever, or projectile vomiting. Altered level of consciousness is not noticed. Patient is fully conscious. There is no history of fits, unilateral weakness of the body, or severe headache, however there is burning sensation in the feet. There is no pain in the stomach, regurgitation of food, difficulty in swallowing. Patient has no history of weight loss, decreased appetite, lumps or bumps in the body, stomach ulcer. Patient has discoloration of the sclera. The right hypochondrial pain and gallstone history is there. And the abdominal pain in the right hypochondrium, it is radiated to the tip of the right shoulder after eating some greasy meals. There is no history of loose motions or constipations. Patient at times used long term medication of painkillers. There is no history of chemotherapy in past or alcohol abuse in the past. Patient diagnosed as diabetic 15 years ago on the basis of clinical features, that is increased urination, increased thirst, and confirmed by fasting blood sugar level, HbA1c level. Patient advised to took oral medication at that time 15 years back, and diet control advice was given. 2 years back he was advised subcutaneous insulin therapy, but patient remained non-compliant with insulin regime and has poor blood sugar level controls. So patient developed loss of vision in both eyes, numbness on both legs. 2 years back, patient was also diagnosed as a case of hypertension on the basis of headache when followed by general practitioner. Patient was advised antihypertensive medication with the name he cannot remember by the doctor, but he was also poor compliant with the antihypertensive medication. History dates back that 10 years back he has a lumbar pain, following which the doctor who advised ultrasound abdomen and some blood tests. There was no other information. But patient remembers that he has renal stones and poor conditions of the kidney on sonography, and then he was shifted 3 years back on dialysis. He did 3 to 4 sessions of dialysis, but after that patient also became non-compliant with the dialysis. Patient denied any cardiovascular disease, sudden severe chest pain, or ever admitted in cardiology ward. A history of smoking was negative. However, there were increased lipids in the blood, for which he was advised statin. Now patient feels extreme weakness and difficulty in standing from sitting position, paleness of complexion. There is no bleeding from any part of the body. However, patient has frequent episode of hypoglycemia, for which he was treated in the past. Patient was advised number of medication that is not remembered by the patient, but he said that these medications were for hypertension, decreased urinary output, and patient became dizzy sometimes after taking these medications. There is no history of allergy to any medication. Patient has no addiction to any substance. Whenever patient delays the dialysis session, he becomes breathless and was brought by his kins to the nearest dialysis center, and after dialysis his shortness of breath resolves. Patient lives in a 2-room compartment. His home expenses are afforded by his in-laws. Patient is not depressed. and hopeful that at time he will recover. Now, what are our differentials on the basis of this history? A long-standing history of diabetes mellitus, hypertension, and dialysis with non-compliance of treatment. The first differential is acute kidney injury on chronic kidney disease with background of diabetic nephropathy, nephrolithiasis, and drug-induced nephropathy. On examination, middle-aged male sitting in bed in prop-up position using 3 pillows, ill-looking, pale, shallow color, puffy face, and sunken eyes. Blood pressure 150 by 90, heart rate 86 per minute, respiratory rate 24 per minute, and temperature is 98.6 degree Fahrenheit. Having IV cannula passed on his right hand, CVP passed on left subclavian vein, chylonychia, shiny nails, leukonychia, and pinprick marks on the fingers of both hands are noticed. No tremor, clubbing, chylonychia, but there are bruises on both forearms. There is bilateral cataract and bilateral pedal edema. Multiple scratch marks all over his body. No other positive findings on skin or skin pigmentation noticed. The oral hygiene is poor. Shape of abdomen is normal, umbilical central inverted. No scar marks over abdomen. No visible veins or pulsations. Soft, non-tender abdomen. Liver is 14 cm in size. Upper border in 5th intercostal space. Lower border is normal and is not palpable. Spleen is not palpable. Kidneys are not palpable, not palatable. Bowel sounds audible. No bruit in abdomen, and shifting dullness is negative. The shape of the chest, trachea is central. No scar over the chest except the CVP line on left side in neck. There is decreased chest expansion on the right side. And right infrascapular region is dull on percussion. And there are end inspiratory crackles bilaterally in the lower chest. Higher mental functions are intact, motor system intact, cranial nerves intact. The sensations bilaterally, it's a gloves and stalking pattern, and 2-point discrimination and position sense is reduced. The plantars are equivocal. The absent ankle reflex or delayed ankle reflex are noticed. Cardiovascular system is normal. The final diagnosis of this patient, it is acute kidney injury on CKD complicated by diabetes mellitus, paired with peripheral neuropathy and cataract and urosepsis, and right-sided pleural effusion. So, now what is the treatment of this patient? The treatment of this patient is that he needs intensive care unit admission with all his baseline investigations like CBC, urea, creatinine, electrolytes, LFTs, ABGs, chest X-ray, protein creatinine ratio, urine for schistocytes. If element of infection is there, a broad spectrum antibiotic with MRSA cover, and integrated management with consultation from nephrologist, internal medicine, and endocrinologist. Thank you very much.